Okay, before I get started, I want to talk a little bit about leukemia, cytogenetics, and pathology, because the chromosome results are really kind of dovetail in with what the pathologist looks at when trying to figure out what kind of cancer this is, or for the oncologist, what they do. So we're first going to talk about leukemia. And this is just some basic information. Leukemia affects 1.5% of the population. It involves cells of the bone marrow. And one of the important things I keep saying over and over until you're sick of hearing it is cancer is an acquired genetic disease. There are unique chromosomal abnormalities acquired in the cancer cells, especially in leukemia, which give them a selective advantage to grow faster. So remember, what every cancer likes to do, they're very evil, is grow forever and never die. And they try to find ways in the genome to make that work for them. So when we talk about cancer cytogenetics, and this is a little bit different than what we talked about in sexual reproduction, germline changes are things that you're born with that came in the egg or sperm, a change in the amount of genetic information, or either deletion or translocation. Acquired or somatic are things that happen later, things that happened in the cells, like later in the process, so after conception. So chromosome analysis in cancer. Analysis of both bone marrows and solid tissues have been shown to aid in both the diagnosis and prognosis of hematologic and solid tumors. Again, they're just one of the tools that the pathologist uses. Many of the hematologic and solid tumors have specific somatic, again, we weren't born with these changes in our chromosomes. Understanding the genes involved in these changes has led to specific treatments that have improved prognosis for many of these cancers. And the first one I want to talk about is chronic myelogenous leukemia, or CML. CML accounts for about 15 to 20% of all leukemias, and it usually occurs between 40 and 50 years of age. 90% of patients with this particular type of cancer, chronic myelogenous myeloid leukemia, or CML, have a translocation between the long arms of chromosomes 9 and 22. Just to go through a little history, it was the early 70s when they identified this. And this is actually what it looks like. Was known as the Philadelphia chromosome. They saw this little curmudgeon thing that they didn't know what it was. And as we got better at looking at chromosomes, they actually realized it was coming from 9. So there was a balanced rearrangement between 9 and 22. And while it's balanced, there's a problem involved here, and that's with regards to why this occurs. And again, the person was not born with a 922 translocation. They were born with normal chromosomes. But in the cancer cells, there's this balanced rearrangement. Why is this happening, and what do we do about it? So the ABL, or the human homologue of Abelson murine leukemia virus oncogene, I swear to God I didn't make this name up, has been mapped to 922. I don't know why it's named that, but that's why they call it ABL. This gene is translocated next to the breakpoint cluster region, or BCR, located on 22q11. We're not sure what happened first, the chicken or the egg, but once this translocation occurs, it increases the cell's selective advantage to grow forever and never die. The fusion between BCR and ABL activates the tyrosine kinase pathway. And again, it took many years between, this is interesting, we see this translocation between 9 and 22, and this is what it does. So the tyrosine kinase activation stimulates division, growth, migration, and transcription factors. So here we have, when the tyrosine kinase is activated, it does all the things cancer loves: increases cell proliferation, decreases cell death or apoptosis, and also changes the adhesion properties. Once cells get too crammed together, they stop dividing, but it got rid of that too. So they just keep growing, without any kind of restrictions. increasing growth, inhibiting apoptosis is the goal for all cancer cells. Like this is the, the trifecta here. Now, in cytogenetics, we can see those chromosomes, but another method that we can use to quickly identify if there's a BCR-ABL, and we can do this within 24 hours, is using FISH, or fluorescent in situ hybridization. And as I said earlier with the developmental lectures, we don't use FISH very often. If I think a kid has a deletion on 22, I'm going to get a microarray. But this is actually a method that we basically use daily. So we'll have two probes. One is a red probe for the ABL region and a green probe for the BCR region. Now, when I look under the microscope, what I'd expect is two reds and two greens, because there's 2 copies of 9 and 2 copies of 22, and they're separate. But when there's translocation, I'll see 1 red, 1 green, and either 1 or 2 fusions, depending if I'm using a single fusion probe or sometimes I have a dual fusion probe. And red plus green equals yellow. That's according to the color thing, so red plus green, you end up with a yellow fusion. So here we have a normal. I look under the microscope and I see 2 green dots and 2 red dots. Here we have a red, a green, and a fusion. This is actually a dual fusion probe that we're seeing the 922 and the 22-9, and a red and a green. I can look at 500 of these relatively quickly and even find low level of this particular fusion. So it's a really quick way for us to determine if a patient has BCR-ABL. Why is that important? Well, it's actually really important because there's now medications that can be given. So this gene product has been found to be involved in worse prognosis in CML, but when eradicated from the bone marrow, can actually improve prognosis. We also can occasionally see this 922 in ALL, and that's a really bad prognosis. But what works for this is something called Gleevec, or imitably mesylate. And this dysregulates, and you're going to learn more about this medication from pharmacology, but I'm just talking about the mechanism of action. So it dysregulates the BCR-ABL fusion protein. And what happens is this Gleevec plops itself right into this site, so the ATP cannot, and it cannot amplify and result in leukemia. So we're actually slowing down the system that's doing the trifecta of grow forever, never die, don't be bothered by people next to you. Okay, so this is just a quick video of Gleevec. So here we have our substrate, and here our ATP, and now we can amplify. But in the BCR protein, we have our substrate, but then we shove Gleevec right into this receptor site, and there's no place for the ATP to attach, so it can't activate the tyrosine kinase situation there. So the next cancer I want to talk about is acute promyelocytic leukemia, or APL. There are a lot of different chromosome translocations, and pathology might speak of more. I'm just going to kind of deal with BCR-ABL and APL, because that's what, if you understand these concepts, that's what you need for step 1. So in APL, acute myelogenous leukemia, 90 to 97% of patients will have a fusion, including the 17q region, and most have a translocation between 15 and 17. So here's our normal 15, and here's our normal 17. This little part of 17, see this band here, ends up over here on 15, and then this area ends up over here. So next I want to go to the next slide. So here's our next slide, and you can see here's the PML in 15 and the RARA, and then when there's a translocation, we see PML RARA and RARA PML, and here we have our fish, we have two 15s that are green and two 17s that are orange. That's what we expect to see. But if we see one red, one green, and a yellow, which is a fusion, that's a sign that there's a fusion between PML-RARA. Myelodysplastic syndrome is just one other thing I want to discuss. Is it's usually the pre-leukemias. It occurs in about 1 to 12 of every 100,000 individuals, and about 50 for every 100,000 in individuals over 70. So this is like, as people get older, their risk for myelodysplastic. Some people progress to AML quickly, so 20 to 40% will develop AML, and some will do it within a year, and some will do it within 20 years. So if you have a 70-year-old who's has signs that they may not progress to AML for 20 years, do you want to really give them chemo or do anything to them? Because let's not worry about what's going to happen when they're 90. Whereas other signs in the when we look at the chromosomes, indicate they might go a little bit quicker. So a third of patients have some type of chromosomal abnormality, and the common ones, again, this is not something I use your neurons on, but deletion of 5, -7, and +8. Again, these are not in the germline cells. They're just here in the chromosomes of the cancer cells. About 30% have just this, then this is 5q deletion. There's a piece missing on the long arm of chromosome 5. And this is actually associated with a good prognosis. Some cytogenetic abnormalities are actually better than normal chromosomes in these cancer situations. So if we saw this, a 5q minus, and they were a 75, 80-year-old with MDS, we might not do anything. Which leads us to ALL, or acute lymphocytic leukemia. And this is more common in children than adults. Median age of occurrence about 3 to 5. Fortunately, it's rare, and there seems to be a male predominance. But there are almost 100% of children with ALL will have some type of chromosomal abnormality if we look hard enough. Sometimes, normally, we look at 20 cells. We might have to look at 50 or 100. But there are a lot of different things that can go wrong. One is extra chromosomes, hyperdiploidy. Instead of 46 chromosomes, maybe more than 50. Tel-AML is a specific translocation seen in ALL, which you can't see looking at the chromosomes. You need to use FISH because it's so hidden. Other kind of common thing, occasionally there's BCR-ABL. This is actually a bad thing when we see BCR-ABL. And then fortunately, the worst prognosis is missing chromosomes. So having less than 40 chromosomes or less than 30 chromosomes is really, really bad thing. So prognosis, hypodiploidy, bad. Hyperdiploidy, good. 922 is actually really bad. So in CML, and we can treat it with Gleevec, but in CML, that's what the common thing is. But when the pathologist feels that this is ALL and we're seeing 922, it's a bad thing. But the 1221, which again, I can't see looking at the chromosomes, but it's actually a pretty good prognosis. So again, I don't want you guys to memorize. I want you to know 922 and 1517 and, CML and APL, which is a form of AML. And that, I guess for ALL, they're pediatric and loss of chromosomes really bad and gain of chromosomes is pretty decent. So cytogenetic abnormalities are actually vital in determining the prognosis of leukemias as well as some of the treatments. Understanding the cause can help us to figure out what to do. And sometimes this takes a very long time. FISH, or fluorescent in situ hybridization, using specific probes, and these are called fusion probes, can help us figure out in a relatively quick manner within 24 hours if that translocation is there. So we don't have to spend a lot of time. And then the doctor can start the appropriate medication. And again, these FISH probes are specific for the certain like thing that we're looking for. So if I think somebody has CML, I have to use the FISH probes for 9 and 22. Or if I think somebody has AML, I have to use the specific FISH probes for 15 and 17 to get that information. So that concludes this module. And again, I've tried to link this as much with Dr. Poole's information so that we can